what I'll attempt to do, I'll try to talk about some of my work on frontal lobe function and dysfunction and how it may have implications for traumatic brain injury. Well, the first question is then, why does our work on executive functions have implications for traumatic brain injury? The answer to that is very simple. There is an increasing interest in the role of executive dysfunction in cognitive sequelae of TBI, and this is a rather universal phenomenon. Traditionally, when people talk about cognitive consequences of various forms of brain damage, the emphasis has been on memory, on language, but over the last few decades, practitioners in various fields have increasingly realized that executive functions are particularly vulnerable, and it's important to study them in the context of various disorders. Now, by way of a digression, even though most of you probably do not work in the field of dementia, it's important to note that a similar kind of a change of emphasis happened in the field of dementia. If you look at DSM, diagnostic manual used very widely in the United States and probably here in Greece, you will note that traditionally dementia has been defined as deficit of memory plus deficit in X number of other cognitive domains. Well, by that yardstick, Pick's disease would not be dementia, Lewy body would not be dementia. So kind of a more recent attempts to understand dementia have been increasingly guided by this notion that executive functions are also impaired and maybe even more impaired than memory. And a similar kind of a change of emphasis has taken place in the cognitive studies of traumatic brain injury, particularly as it pertains to mild traumatic brain injury. In Dr. Flanagan's discussion, he mentioned that the vast majority of cases of TBI, in fact, are cases of mild TBI. Well, what does that mean? Cognitively, it means that their MRI may be normal. It means that even a run-of-the-mill neuropsychological battery may fail to reveal much by way of cognitive deficit. And very often it is said that in these patients, personality changes. And people talk about personality as if it were an extracranial attribute like the color of our hair. But in reality, these subtle and sometimes not so subtle changes in personality is nothing other than subtle forms of executive dysfunction, dysfunction of the frontal lobes. So these are all the reasons why the discussion of frontal lobe function and dysfunction does belong in this conference. And basically, my talk will be, in fact, a juxtaposition of two somewhat separate talks, one related to some of my old work and how it may elucidate the mechanisms of executive dysfunction in TBI, and the other one pertaining to how cognition and cognitive impairment in TBI, as it pertains to executive dysfunction, can be measured across various etiologies, including TBI. Now, so with that, let me start and sort of dispense with the kind of unnecessary platitudes. Of course, when we talk about the prefrontal cortex, there are various ways of defining prefrontal cortex. And let me start with a certain kind of a terminological clarification. Very often people refer to a terminological shortcut, and they talk about the frontal lobes. In fact, I'll probably be doing it all along through this talk, when in fact they mean the prefrontal cortex. Though the frontal lobes is this large lobe, the largest of the cortical lobes, but the prefrontal cortex is just a subdivision of the frontal lobes, which can be defined variably through architectonic regions by saying that the prefrontal cortex is Brodmann area in part 6, but certainly 8, 9, 10, 11, 12, 45, 44. It may be defined in terms of its thalamic projections, and then people say that the prefrontal cortex is that which receives projections from the dorsomedial thalamus. It may be defined in terms of its biochemical projections, and then people say that the prefrontal cortex is that which receives projections, dopamine projections from the ventral tegmental region. But basically, all these definitions amount to roughly the same, and I am outlining this area with my laser pointer as we speak. Okay? Now, no author will miss an opportunity to plug his own books, and so I'm doing it as we speak. So virtually everything that I'm going to talk about can be found in my books, The Executive Brain, The Wisdom Paradox, and this very recent book, The New Executive Brain, which is sort of a successor book to the old Executive Brain published by Oxford University Press. Now, undergone, by our, I mean kind of a collectively neuroscientific interest in the frontal lobes, has undergone very dramatic change over the last half a century. Now, I recall the late Patricia Goldman-Rakish. How many of you know this name, Patricia Goldman-Rakish? She was one of the most remarkable and most important students of the frontal lobes who died tragically in a car accident a few years ago. So I recall many years ago, she was giving a talk at Columbia University, and I was in the audience, and she showed this kind of an outline of the brain, schematic outline of the brain with little homunculi drawn into various lobes, and there were a lot of them in the occipital lobe, in the parietal lobe, in the temporal lobe, very few in the frontal lobes. And that was meant to denote, kind of in a tongue-in-cheek fashion, that there was relatively little research interest directed at the frontal lobes. Now, that was about a quarter of a century ago. And a lot has changed since, and today, of course, the studies of the frontal lobes and executive function is among the hottest, if not the hottest, sort of area of cognitive neuroscience. So the understanding of how this complex machinery of frontal lobe function may be broken bears direct relationship to the understanding of the cognitive impairment in TBI, and we'll talk about it over the next few minutes. Well, when people talk about the functions of the frontal lobes, these are the kind of the cognitive domains which are usually alluded to, and this is capacity for goal-oriented behavior, capacity for planning and temporal organization of cognitive processes, capacity for critical judgment, the ability to project into the future and to anticipate the consequences of one's own behavior and behavior of other people, capacity for insight into the minds of other people, so-called theory of mind, impulse control, and some other functions. Now, well, as Dr. Flanagan already said, the internal aspects of the cranium is a rough surface, and the frontal lobes are particularly vulnerable to the effects of head injury for several reasons. One reason is one of cranial anatomy. The orbital aspect of the frontal lobe is a particularly likely site of contusion. The other reason is sort of more elusive, and but may something to do with that which was captured in this old classic formulation by Hewlings-Jackson, who introduced this law of evolution and dissolution, whereby the phylogenetically younger structures are, for some reason, not fully understood, are particularly susceptible to the effects of any kind of brain damage. And yet another reason is white matter pathway vulnerability, and this is one of these little kind of vignettes which I would like to bring into the discussion here. Now, it is sometimes said that every clinician has certain formative cases which to a large extent educated him or her and shaped his or her subsequent interests. So this is one of my cases, a case which we encountered many years ago, where and Yehud, I think you were involved in the care of this patient also. A patient a man in his mid-30s at the time, who fell off a horse. It was a horse riding accident. When he was brought to my attention, he struck me as a flagrant textbook case of frontal lobe syndrome. He was aspontaneous, he was affectively disinhibited, he was echolalic, echopraxic, he was perseverative, there was no capacity for insight, there was no capacity for foresight. So it was a textbook case, behaviorally and cognitively, it was a textbook case of frontal lobe syndrome. The puzzle was, the riddle was that the CAT scans, and we're talking about at least a quarter of a century ago, so what you are, almost 30 years ago, so what you are staring at is one of the early generation CAT scans, but several of these scans were administered, and there was no evidence of damage within the prefrontal cortex. Clearly, this man's brain was affected in many ways. His ventricles were enlarged. There was this bilateral temporoparietal damage, but the frontal lobes per se were clean. There was no evidence of structural damage to the frontal lobes, yet clinically and behaviorally, he exhibited every classic feature of frontal lobe syndrome. So what we found, and that was not an incidental finding. We sort of anticipated this finding and in fact directed our radiologists to look at the brainstem with particular care. But what we found was a lesion outlined by these two arrows sitting somewhere between the pons, mid-pontine region, and the ventral tegmental area, narrow, long band of hyperdensity. Probably as a result of herniation, but whatever caused it, it was there. And anatomically, when we overlapped this lesion with standard anatomical atlases, we concluded that basically it wiped out the area which in those days was somewhat obscure, but today is all the rage. It's an area of great interest in many chapters of cognitive neuroscience, ventral tegmental area, which is often known as VTA, and this terminology did not even exist in those days. So that gave rise to this condition which I described, and we introduced it into the literature under the name of reticular frontal disconnection syndrome. Of course, the notion of disconnection syndrome is a classic notion introduced by Norman Geschwind, but the classic disconnection syndromes pertain to cortical disconnections. Here we postulated the existence of sort of vertical disconnection syndrome, disrupting pathways projecting from the ventral mesencephalon into the frontal lobes, and these are bidirectional pathways. When people talk about these pathways, people usually emphasize their ascending component, but in reality these are bidirectional pathways. We postulated that it was precisely damage to these pathways which produced this frontal lobe syndrome without a frontal lobe lesion. Why am I telling you about this old case now? Well, it was obviously an interesting case. Now, these were the days when Science magazine basically did not publish much in the field of neuroscience or neuropsychology. In those days, our discipline was sort of considered outside the pale. By our discipline, I mean neuropsychology, considered outside the pale of kind of a serious, rigorous disciplines. I recall when I first began to use the term cognitive neuroscience in the company of kind of colleagues dealing with biochemistry, neurochemistry, molecular neuroscience, they basically frowned and did not sort of understand what I was referring to by this term cognitive neuroscience. But today, of course, if you open any issue of Science or Nature magazine, you will see something related to the brain. In those days, that was almost unheard of. But, you know, they published this paper in Science describing this case precisely because, you know, we argued successfully enough to pass the muster by their reviewers, evidently, that this pathway was very important in sort of explaining the interaction between the various aspects of the arousal system and various cortical functions in some important ways, okay? Now, so I do believe that damage to these pathways is critical to the cognitive manifestations in close traumatic brain injury, particularly in so-called mild-traumatic brain injury, whereas Dr. Flanagan mentioned in his talk, the CAT scan or MRI may be normal. There may be even very little by way of cognitive impairment demonstrated on kind of a run-of-the-mill neuropsychological batteries. Yet there are these subtle personality changes. Now, well, we know that this is a very important pathway. This, the ventral tegmental pathway, which is a part of the medial forebrain bundle, has been, dysfunction of this pathway has been implicated in a wide range of conditions outside of the world of TBI. It has been implicated in schizophrenia. I mean, when people talk about the mesocortical dopamine pathway, this is this pathway. It has been implicated in attention deficit hyperactivity disorder. When people talk about the mechanisms of ADHD, again, this interface between the prefrontal cortex and the arousal mechanisms of the ventral brainstem is implicated. So we know from the studies of other diseases that this is a very important pathway. I mean, we also know, based on more direct studies of TBI, that white matter suffers in traumatic brain injury. And we know, as Dr. Flanagan indicated, and we also know that midline structures suffer in traumatic brain injury. We all come, well, both of us and Dr. Yehuda Ben-Ishai come from NYU. There is a very strong radiology program, neuroradiology program at NYU, and some of their work has demonstrated in a very compelling and dramatic way the vulnerability of midline structure, and that has been known in your world, in the world of TBI. But if you put two and two together, what are the structures which are both midline and white matter? It is the medial forebrain bundle. It is precisely these pathways which we are talking about. So if you are saying that white matter is vulnerable and midline structures are vulnerable, so clearly those structures which are both midline and white matter should be particularly vulnerable, and there is only one such a set of structures, and this is the medial forebrain bundle. So on these grounds alone, one should pay close attention to it in trying to understand the mechanisms of executive deficit in traumatic brain injury. And of course, we know that the relationship between the extent of structural damage to various white matter pathways And the degree of the cognitive functional ramifications of this damage is a complex one. We know that, for instance, that white matter, that corpus callosum is quite vulnerable structurally in TBI, but at the same time, there are many reasons to believe that the functional repercussions of this damage are minimal, okay? Think of the work by Roger Sperry, who got his Nobel Prize for severing the corpus callosum, and basically they were not finding anything in terms of real-life implication. The work by Gazaniga and the Ransdell, etc., really had to involve some very refined neuropsychological tests to elicit the deficit caused by this severance of the corpus callosum. In terms of real-life ramification, the deficit was rather insignificant. By contrast, based on what I said about the kind of postulated role of this medial forebrain bundle in a wide range of diseases outside TBI, there are reasons to believe that even kind of a structurally modest damage to the more to these pathways emanating from the brainstem to the frontal lobes may be wrought with significant cognitive repercussions. Now, well, of course, now we have tools to examine the damage of white matter in ways which was not possible a few decades and even a few years ago. And here we're talking about various techniques such as diffusion tensor imaging, diffusion kurtosis imaging and such. And again, our colleagues at NYU have been at the forefront in developing these methodologies. Now, the trick is that this particular pathway, the one that we're talking about, this medial forebrain bundle, seems to be relatively elusive to such imaging, and not readily amenable to such imaging for a variety of reasons, as explained to me by radiologists, reasons being that, first of all, this pathway is very skinny. Those of you who are familiar with diffusion, those of you who have seen pictures generated by these various imaging techniques and highlighting various pathways will recall that basically they are very good at imaging the corpus callosum. They are very good at imaging corona radiata. They are very good at imaging even at longitudinal cortical fasciculi, but these are large bundles. By comparison, this medial forebrain bundle is puny. It is a very small bundle, and it's also a bundle characterized by a fair amount of pathway crossing. So for all these reasons, neuroimagers have not been very successful at imaging it. And the point that I am making is that it's very important to learn how to image these particular pathways, because by so doing we may end up elucidating some very important mechanisms which underlie cognitive dysfunction, so-called mal-TBI, particularly as it pertains to executive dysfunction. And of course, now there are other methods which the people at NYU are using increasingly to assess the connectivity indirectly, not through direct pathway imaging, but through looking at sort of time series of activation in resting functional MRI. So these are all technologies which we hope to bring to bear on this whole subject. Well, so this was what I wanted to tell you about, share with you some of my thoughts about the mechanisms of mal-traumatic brain injury. Now, what I want to do now is to talk about something entirely different, even though maybe these two kind of foci of my presentation can be interrelated in the end, and we'll try to do so. And that is how to assess the cognitive dysfunction in traumatic brain injury. And of course, before we talk about assessing cognitive dysfunction, it's important to sort of sharpen our understanding of the normal function of the frontal lobes, and that will help us develop tools to examine the dysfunction of the frontal lobes in various conditions. And in my own work, I've been particularly interested over the last 2 decades, I would say, in the role roles of the frontal lobes in dealing with cognitive novelty and dealing with cognitive ambiguity. And of course, there are many clinical observations linking damage to the frontal lobes to the ability to loss of the ability to deal with cognitive novelty and the ability to deal with underdetermined cognitive situations. But it has not been much of the focus of kind of formal studies of frontal lobe function in cognitive neurosciences. I mean, those of you who are familiar with the work on the frontal lobe function, with various tools of cognitive neuroscience, will recall that the emphasis has been on working memory, which is a good thing, but a mixed blessing, because this emphasis has taken place to some degree at the exclusion and at the expense of sort of the interest in other facets of frontal lobe function. So in my own work, we focused on the role of frontal lobes in dealing with novelty and dealing with ambiguity. And just to demonstrate for you how critical the studies of cognitive novelty are. Here is an example from an old study which we conducted in collaboration with Kai Vogelei, a German neuroscientist, then at the University of Bonn, looking at a different aspect of the neural machinery of dealing with novelty, specifically at the relationship between cognitive novelty and hemispheric specialization. Now, here, basically what it shows, and I will not bore you with the description of the specific cognitive task that we used, but basically we alternated situations when we asked normal subjects to either attend to familiar components of some cognitive stimuli or to unfamiliar novel components of cognitive stimuli, and then depending on the instruction, either the left hemisphere, including the left frontal lobes, prefrontal cortex, this is kind of a left dorsolateral structures, or the right frontal, or the right hemisphere, including the right dorsolateral cortex, were activated. So really, this goes to show that there is a somewhat that the brain deals somewhat differently with familiar as opposed to novel situations. So we were interested in studying the brain machinery of dealing with cognitive novelty as it pertains particularly to the frontal lobes. And to that end, we try to develop kind of a novel cognitive methodology. And again, as I said earlier, much of my life's kind of a lifelong professional interest revolved around the frontal lobes. And by a certain time, by a certain stage in this career, I sort of began to feel that we are measuring blood pressure with a thermometer, that there was a major disconnect between and mismatch between the kind of a neuropsychological tools in our possession, which we were deploying to the studies of the frontal lobes, and the actual function of the frontal lobe. That really we needed, and of course, those among you who are neuropsychologists or behavioral neurologists know that there is a whole slew, a whole collection of neuropsychological probes, neuropsychological tests designed to investigate frontal lobe function. And by a certain point in my sort of career, I began to feel that they were missing some very important aspect of frontal lobe function, and we needed a very radical kind of a paradigmatic departure from what we had in order to really fully elucidate the frontal lobe function. And that gave rise to the distinction, which I'll spend a few minutes explaining to you, distinction between actor-centered decision-making and what I call veridical decision-making, and the role of actor-centered decision-making in the frontal lobes. And so let me explain this difference. I mean, and at the risk of sort of insulting your intelligence by rhetorically asking you a very simple question, let me ask you this question. Well, what is the difference between two cognitive tasks? One cognitive task is exemplified by a question, how much is 5 plus 5? And the other cognitive task is, imagine you sit in a restaurant, you're staring at the menu or trying to decide whether to order a steak or a duck. All right? Now, well, what's the difference? The difference is 5 plus 5 is 10. And it's a problem which has an answer, a correct response. All other responses are incorrect. If you were to say, well, I wish 5 plus 5 were 15, well, sorry, it isn't. It's 10. And what's true and what's false is inherent in the problem, and it does not depend on the problem solver. It is a veridical question, and the task here is to find the correct response. But by contrast, if you sit in the restaurant and staring at this menu, or to use a less frivolous example, suppose you graduated from college and you have to decide whether to go to medical school or to law school, saying that medical school is an intrinsically correct choice, physicians among you may disagree, and law school is an intrinsically false choice, is an oxymoron. Just the true-false distinction just does not apply to this type of decision-making. Here, decision-making is directed not at finding the correct response, intrinsically true response, but deciding what's best for you. Here, the choice of the solution arises on the intersect of the external features of the task and internal attributes of the problem solver in a way that 5 plus 5 equals 10 does not. Okay, so these are two very different types of problem solving, and based on everything that we know about the brain, we have good reasons to believe, well, I am known for running ahead of my slides, and I've done it again. So this slide basically summarizes what I said a minute ago, and so does this slide. But based on what we know about the neural territories of these two types of decision making, and then again by way of significant simplification, but with a sufficient kernel of truth to allow it, permit it here, one could argue that this veridical decision making is mostly supported by posterior association cortices, and this actor-centered decision making is mostly supported by the prefrontal cortex. And just to highlight that what I'm saying is not just some kind of a casuistic semantic focus, let me just say that people who try to model these two types of decision making with formal models, formal neural nets, which are computer simulations of the brain, and some of my earlier work that touched quite substantially on these methods, concluded that these two types of cognitions require different types of models, that veridical decision problem solving is really best modeled by so-called Hebbian networks, and this actor-centered decision making is best modeled by a totally different type of neural architecture captured by so-called backpropagation models. And the only reason why I'm mentioning it here is just to highlight that this distinction which I am drawing for you is not just kind of a semantic verbal trick, okay? That really when you try to operationalize these two types of decision making, you end up with very different neural architectures. Now, so much, but again, those among you who are neuropsychologists, now think about all the tools of neuropsychological diagnosis at our disposal, virtually, and even think of the paradigms used in cognitive neuroscience with neuroimaging in normal subjects to understand the function and dysfunction of the frontal lobes. Virtually all of them are veridical. We have precious little, bordering on nothing, to look at actor-centered decision-making. And, you know, once I reached this conclusion, sort of, you know, I became quite convinced that our failure to sort of note the importance of this non-veridical actor-centered cognition and lack of tools to look at it basically prevents us from fully explicating the function of the frontal lobes in very important ways, okay? So much of my own work and that of my colleagues focused on the development of these non-veridical actor-centered tools. And let me talk very briefly about some of this work and show you some of the studies involving intentionally very simple paradigms. Now, imagine that you are asked to, you have a series of these geometric, kind of a triplets of geometric forms, and imagine you are asked to look at this geometric form on top, and then the instruction is look at this one and then choose one of these two which you like the most, okay? And we explain to the subject that there is no true correct or true incorrect. Don't try to second guess it. It's truly a preference task. And there is a series of such stimuli, and the subject operates under the impression that it's a task of free choice, okay? But of course we know that freedom is an illusion, or if we don't know, I mean, it's time to sort of face up to this reality. And this is something that was first noted by Hegel, I think. He is credited by the somewhat cynical or nihilistic statement that freedom is an illusion. And then in a somewhat sadistic fashion, it was appropriated by the classics of Marxism, Leninism. I grew up in the former Soviet Union, and one of the maxims attributed to these people with a somewhat sadistic twist was that freedom is necessity recognized, which every citizen of my old country was forced to understand very well. But in any event, in this experiment too, even though the instruction is to engage in free choice, we can counterbalance the stimuli in a way which really forces the subject to engage, to choose out of a finite menu of possibilities unbeknownst to him or to her. And we are in a position to know exactly what guide the subject's decision-making, even though subjectively it's, you know, it's free choice, okay? Free choice is never entirely free, nor was it in our experiment. Now, well, the first thing that we wanted to do is to really see whether this methodology, and we've had a whole family of such tasks. I'm talking about only one of those, which is the simplest one. So the first thing that we want to do is to see whether indeed it activates the prefrontal cortex, and it does. So this is from a study conducted with Japanese colleagues using high-resolution SPECT, which shows that this the preference task activates the prefrontal cortex and does not activate anything else, okay? So at least in this study. So that was reassuring. This is a similar study conducted in collaboration with Kai Fogelei, whom I mentioned earlier, using functional magnetic resonance imaging. All these pictures that I'm showing you now are with normal subjects using fMRI. Again, unsurprisingly, this task activates the occipital parietal regions, unsurprisingly because it's a visuospatial discrimination task, but it also activates the dorsolateral cortex. But then the interesting thing about this task is that you can disambiguate it. Suppose you ran it with the instruction that I told you about, look at the target, then choose one of those which you like the most, and you have done that. Then you can run the same task again, and now you can ask, look at the target, and choose one of these two which is more similar or which is more different from the target. And we always design this task in a way that one of these two items is truly more similar and the other one more different from the target. So now we have disambiguated the task, and without changing any of its physical properties, that we turned an actor-centered task, a preference task, into a veridical task, because truly there is always one item here which is more similar to the other one which is more difficult. More different. And this is an important feature of this task, because those of you who are familiar with functional neuroimaging methodology, it is important whenever you engage the subject in a cognitive task, it is important to have in conjunction with this task a so-called baseline subtraction task. And a whole methodology, which is sometimes referred to as subtraction methodology, sort of evolved around these issues, so that you characterize the cognitive activation associated with the task by looking at the differences in the activation patterns between the critical task and the baseline task. Otherwise, you wouldn't know which aspects of brain activation while the subject is doing the task are truly related to the task, and which are related to the fact that the subject is also experiencing a mild toothache, or thinking about his wife, or about his bad dinner the night before. Now, so and it has been noted by many authors in the literature that the proper choice of the subtraction task is every bit as important to to this whole cognitive activation neuroimaging enterprise as is this abstraction of the critical task. So here, this is the slide that I've already shown you, which sort of shows patterns of activation under the conditions of this kind of a preference task. And this is what happens once you disambiguated the task. Now, this is what happens when you add the subject to select on the basis of similarity or dissimilarity. No, this is dissimilarity, difference, yeah. And what you see is that the occipital parietal activation remains, frontal activation disappears, which is, again, think of the SPECT slide which I showed you a minute ago, which shows here in a very controlled fashion that, that the prefrontal activation is very specifically related to the non-veridical actor-centered aspect of this task, and this is what we want, okay? This is yet another demonstration of the same, and I'll show you this slide later today in our workshop. We'll talk some more about it, using yet another technology. Again, a study conducted in a collaborative study with some Japanese colleagues in Tokyo, using high-resolution EEG gamma frequency. And the gamma frequency, 30 to 40 hertz frequency, has been used by many people as a marker of strenuous cognitive activity, kind of a mental effort. And you see that when the task remains ambiguous, there is this frontal activation, and then the task is disambiguated, kind of the kind of a cortical cognitive gravity, if you will, center of cortical cognitive gravity shifts away from the frontal lobes toward the posterior cortex. So let me skip this slide. And this is yet another study of a similar kind using a different frequency band. So we developed these cognitive probes to look at actor-centered cognition, but we also are able to demonstrate using some more conventional tasks. It would be a little bit kind of awkward to have an effect with these highly idiosyncratic Goldberg tasks without any collaboration from the task sort of acknowledged by the kind of a neuropsychological mainstay and the kind of a neuropsychological establishment. So we have done that, and this is a task conducted at NYU very recently, a study conducted at NYU very recently, using the task familiar to many of you, the Wisconsin card sorting test, which is kind of the gold standard of frontal lobe testology, has been so for a number of years, where we show, and I won't explain it to you, I assume that people know what it is, but basically it's a guessing game when you are supposed to guess some underlying principle based on feedback. So there is an element of ambiguity in this task initially, and what we do here, we compare the patterns of cognitive activation at an early stage of trying to discover this hidden category, and at a late stage when the underlying principle had been discovered, and use the latter as a subtraction from the former. As I mentioned earlier, the subtraction methodology is paramount anywhere in cognitive neuroscience. And what we have is that indeed there is a selective activation of the prefrontal cortex associated with this novelty stage, which is also an ambiguity stage, which then disappears when the category has been discovered. So again, I'll explain what we are doing. We are splitting the sequence into the beginning of the sequence and the end of the sequence. Beginning of the sequence, George, you know what I'm talking about, you know this task, is when the subject is still kind of in the dark, he's befuddled, he's trying to understand, figure out the underlying principle. The task is ambiguous and it is novel. And the end point, the second half of the sequence is when the subject already discovered the underlying principle, and everything goes fine until the principle changes again. Okay. Now, so when you compare this early and late stage of this underlying principle discovery, you conclude that the early stage is characterized by a particular activation of the frontal cortex, particularly the right frontal cortex, but this is something that we'll talk about this afternoon, and this frontal activation is no longer there when the principle has been discovered, okay? So with a variety of tasks, some of our own kind of a design and some more traditional ones, we are able to demonstrate a kind of a preferential relationship between cognitive ambiguity and cognitive novelty, and the two go hand in hand, and frontal lobe involvement. Now, well, we used, I should have put out my timer. How much time do I have? Yeah. Only. Time flies. We used, so basically I'm getting to the crux of the matter as it may be relevant to the world of TBI only now. We used these tests to do some of the more old-fashioned work. We gave it to patients with frontal lesions and tried to see whether different anatomies of frontal lesions would produce different patterns of performance on this task. And we were particularly interested in the functional lateralization in the frontal lobes and how damage to the left or right frontal lobes may manifest itself on these tasks of ours. And of course, those of you who are familiar with this literature dealing with hemispheric specialization will recall that really functional lateralization in the frontal lobes is not emphasized in this literature. That it's basically ignored, that there is this tacit assumption that from a laterality standpoint, frontal lobes are sort of equipotential without any clear division of labor. Well, this turned out to be not so when we use our actor-centered tests. And the point that I am making is twofold. First of all, to convey certain hopefully useful information, but secondly, to emphasize kind of the particular sensitivity of these non-veridical actor-centered paradigms compared to the more traditional ones. So these are male subjects, normal subjects, subjects with posterior frontal lesions, subjects with prefrontal lesions, and of course when you deal with lesions you deal with kind of a blunt instruments. So really the selection criteria here was the main criterion was that there had to be significant frontopolar and dorsolateral damage, but of course then you get what you study what you get. There could have been associated anterior singular and orbitofrontal and opercular involvement, but the presence of frontopolar and dorsolateral, strictly lateral damage was the sine qua non, okay? So here what you see are the effects of left prefrontal lesions in males and right prefrontal lesions in males. And what basically what does this metric mean, since this is a non-veridical test, there is no correct and no or incorrect, so high does not mean good performance and low score does not mean bad performance. High score means what we call context-dependent behavior, behavior driven by the cognitive context, which in its extreme form is echo behavior. In its extreme form, it is the field-dependent behavior of the sort described by François Lhermitte and my old mentor, Alexander Luria. And low score means context-independent behavior, which in its extreme form means perseverative behavior. So, well, here now the implications for your world, the world of TBI, is very obvious. If patients with somewhat greater, and of course when we talk about close TBI, we don't deal with strictly lateralized lesions usually, but nor do we deal with perfect symmetry, because perfect symmetry exists only in mathematics or in the arts. Whenever the prefrontal cortex is affected based on some functional imaging basis or based on maybe some other evidence, the odds are that that this damage will be somewhat more pronounced on one side than on the other, okay? Now, and so if our findings are valid, and I have every reason to hope that they are, that means that one should expect very vastly different cognitive manifestations of frontal damage, which is mostly right frontal damage, and those which is mostly left frontal damage. You'll have a propensity toward field dependency in one case and propensity toward perseveration in the other case. And of course we know that field-dependent behavior and perseveration are the two most kind of common features of the frontal, kind of a clinical prefrontal bouquet. I mean, these are kind of the two axes of the prefrontal, of the classical prefrontal syndrome. Okay, but it turns out that these two aspects of the prefrontal syndrome are to be expected to be differently weighted depending on the relative lateralization of the prefrontal damage. Let me skip this. And just to highlight something is these are the data that I'm showing you now are the data which I showed you a minute ago, but in a different form, in the form of the scatter plot diagram, where every point corresponds to a particular patient. And you see how the patient cases with left frontal lesion and cases with right frontal lesions, how neatly they are divided. There is no overlap between these clouds. When the effects of these lesions are measured with our non-veridical actor-centered tasks. These are the same patients assessed with the Wisconsin card sorting test, which has been, as I said, many of you know, the gold standard of frontal lobe testology. And what you have here is mishmash. What you have here is total overlap, total absence of separation, which means between the effects of left and right frontal lesions, which means that these veridical tests of frontal lobe function are totally incapable of documenting the functional difference between left and right frontal cortices, whereas our actor-centered probes do it beautifully. And that again goes to show how insufficient the traditional cognitive methodology deployed to measure frontal lobe function and dysfunction is, and how much greater the power of this non-veridical methodology is. And this is, you know, also Wisconsin card sorting test using another index. Just to run you through the remaining now, if I had 10 minutes, a few minutes ago, now I must have 3 left or whatever, yeah. Now, I spoke so far about kind of the lesser half of humanity, so let's compare the two halves of humanity. Here, this is the set of data pertaining to the effects of lateralized frontal lesions in males. We talked about it over the last few minutes. These are females. Now, you don't need to be a neuroscientist, let alone a rocket scientist, to see a difference, okay? In males, the lateralized effect of frontal lesions are vastly different. In females, the effects of lateralized lesions are essentially the same, okay? That there is no, that damage to the left and right frontal lesions in females produce very similar outcomes. In male, they produce vastly different outcomes. Again, something which may be useful to know by people involved with the cognitive rehabilitation of the effects of traumatic brain injury. There are vast gender differences in the effects of effects exerted by TBI on the frontal lobes. Again, something which probably has or can have potentially very direct implication for the choice and design of the cognitive rehabilitation strategies, right? Now, parenthetically, we are planning to use, as you may have already figured, this whole inquiry of ours, was not driven by an interest in any particular disease. It was driven by more basic inquiry, trying to understand the function or dysfunction of the frontal lobes. And of course, frontal lobes are directly or indirectly dysfunctional in a wide range of conditions, which may be characterized by this subtle lateralization, like hemiparkinsonian, okay? To the extent that we know that anyone who has worked with patients with Parkinson's know that most individual cases are characterized by somewhat asymmetry, okay? Most individual cases of Parkinson's disease are somewhat hemiparkinsonian. Well, what does that mean? That probably means that the substantia nigra is affected on one side a little bit more than on the other, but substantia nigra is the source of dopaminergic input to the striatum, and the striatum and the frontal lobes work in very close concert. So there is, and to the extent that cognitive deficit has been sort of documented in patients with Parkinson's disease, It's also along the initiation, mental flexibility. So one can, to the extent that the striatum is implicated, one can think of the cognitive impairment in Parkinson's disease as a functional extension of that which we see in frontal lobe dysfunction because of the close functional unity between the prefrontal cortex and the striatum, okay? So we are now going to, with Alex DeRocco, whom you probably know, develop a protocol looking at patients with hemiparkinsonians, trying to sort of differentially characterize their cognitive profiles using these non-veridical techniques. And in Tourette's, where again neostriatum is implicated, putamen and caudate. Again, there is two of each, one linked to very closely interconnected with the left prefrontal convexity, the other with the right prefrontal convexity. So we'll be using these methods to characterize, differentially characterize the cognitive patterns in patients with Tourette's with the propensity of left or right patterns of hypermetabolism in the striatum, okay? And what I'm saying that these methodologies may be very useful in characterizing cognitive impairment in TBI. Now, just to complete this discussion, with these methods, we have also been able to demonstrate Well, utilization is a form of field-dependent behavior, absolutely, but an extreme form, yes. Yes, the short answer is yes. Yeah. I think that, there is a normal range of these individual differences. Some people may be more context-dependent and others more context-independent within the normal range, and there we're talking about cognitive styles. But once we get outside this normal boundary, the boundaries of this normal range, whatever it is, we hit these two extreme types of symptomatology which have been linked to frontal lobe pathology, and that's perseverations or field-dependent behavior. As far as I'm concerned, utilization behavior is a form of field-dependent behavior on par with echo behaviors, echolalia, echopraxia. They are of the same variety. And what's interesting is that you and I, when we talk about these phenomena, we usually talk about patients with explicit damage to the frontal lobes, but they are present in various forms in other conditions characterized by the dysfunction of the frontal lobes, either directly or indirectly by involving the underlying subcortical striatal machinery. In Tourette's patients, people talk about tics, which are perseveration, okay, as far as I'm concerned. But what is also common in these patients, even though DSM in its wisdom sort of chopped this syndrome in half and sort of put one half under the rubric of Tourette's and the other one under the rubric of attention deficit disorder, is exploratory behavior. These patients are constantly engaged in excessive exploratory behavior, which may take totally, extreme forms. And to me, this excessive exploratory behavior of Tourette's is sort of the striatal subcortical analog of the kind of utilization behavior that Lermite described as a result of direct frontal lesions.
So does that mean then that in our male right-handed patients, we'll only see that after right frontal?
Well, you will answer this question. You have much greater exposure to these patients, but that would be my prediction. I don't have data to support it with because I don't deal with these patients in sufficient numbers. You are, so you do. So it would be very interesting. I would await your comment maybe half a year or a year down the road once you have had a chance to look at these patients. Yeah. Mm-hmm. Yeah.
Yes, please.
Well, the short answer is I don't know, because my own work does not involve functional imaging in ADHD. This emphasis on the right frontal, this is what Russell Barkley said, okay? He said that ADHD is the disease of right orbital frontal cortex. Well, some are, some aren't. ADHD is not a disease, it's a syndrome, which as far as the underlying mechanisms are concerned is a hodgepodge of various underlying etiologies and possibly anatomies. So I would imagine that it's some of them in this Russell Barkleyan subtype, that would be the case, I guess, yeah. Mm-hmm. George, yeah.
Your actor-centered proposition seems to me to rest on interacting of two variables. One is the ability to be sensitive to the social context.
Well, to the context, yeah.
The context. Yeah. But the other has to do with what is interesting to the person.
Exactly.
In terms of what are they aware of. And it's interesting that right frontal lesions repeatedly come up as being implicated when the individual has a lack of awareness or insight of how they've been affected after a brain injury. The question I have for you is, how does the premorbid personality characteristics of the individual interact in these kinds of paradigms?
It's a very interesting question. And I think that these paradigms lend themselves, and this is also something that we may be interested in doing in the future. I think that these paradigms lend themselves just as readily to the subtyping normal population in terms of the cognitive styles. Absolutely. And then, once we have done then it would be very interesting to see. Well, it's the kind of study which is easier to conduct conceptually, kind of as a Gedanken experiment than as an actual study, because ideally you would want to have a group of people whom you subtype pre-morbidly on these tasks, and then wait till some of them will acquire brain damage, and then retain them subsequently. Well, that's a bit of a tall order, but at least as a conceptual experiment, I think that these could be very interesting tools of subtyping normal cognitive styles, yes. Mm-hmm. Yeah.
Thank you.
Thank
Okay.
you.